Lower leg, ankle, and foot conditions anatomy. First, to understand conditions of the lower leg, ankle, and foot, we must first understand the anatomy and associated structures and articulations. An articulation is essentially when two bones or structures come together and form some sort of union, such as our tibia and fibula articulating with our talus to create the talocrural joint. The ankle is made up of the talocrural joint, the subtalar joint, and the distal tibiofibular joint, or syndesmosis joint. The talocrural joint. The ankle or the talocrural region is the region where the foot and leg meet. The ankle includes three joints: the ankle joint proper, or talocrural joint, the subtalar joint, and the inferior tibiofibular joint. The movements produced at this joint are dorsiflexion and plantar flexion of the foot. In common usage, the term ankle refers exclusively to the ankle region. In medical terminology, ankle without qualifiers can refer broadly to the region or specifically to the talocrural joint. The main bones of the ankle region are the talus in our foot and the tibia and fibula, our lower leg. The talocrural joint is a synovial hinge joint that connects the distal ends of the tibia and fibula and the lower limb with the proximal end of the talus. The articulation between the tibia and the talus bears more weight than that between the smaller fibula and the talus. The subtalar joint, also known as the talocalcaneal joint, occurs at the meeting point of the talus and the calcaneus. The joint allows inversion and eversion of the foot, but plays no role in dorsi or plantar flexion of the foot. It is considered a plain synovial joint, also commonly referred to as a condyloid joint. The distal tibiofibular joint, or the tibiofibular syndesmosis, is formed by the rough convex surface of the medial side of the distal end of the fibula and a rough concave surface on the lateral side of the tibia. The ankle joint is bound by the strong deltoid ligament and three lateral ligaments: the anterior talofibular ligament, or the ATF, the posterior talofibular ligament, the PTF, and the calcaneofibular ligament, the CF. The deltoid ligament supports the medial side of the joint and is attached at the medial malleolus of the tibia and connects in four places to the talar shelf of the calcaneus, calcaneonavicular ligament, the navicular tuberosity, and to the medial surface of the talus. Our deltoid ligament is far stronger than our lateral ligaments. Our deltoid ligament is four ligaments all compiled into one area, while our lateral ligaments are three separate ligaments that are nowhere near close to each other. The anterior and posterior talofibular ligaments support the lateral side of the joint from the lateral malleolus of the fibula to the dorsal and ventral sides of the talus. The calcaneofibular ligament is attached at the lateral malleolus into the lateral surface of the calcaneus. Though it does not span across the joint itself, the syndesmotic ligament makes an important contribution to the stability of the ankle. This ligament spans the syndesmosis, which is the term for the articulation between the medial aspect of the distal fibula and the lateral aspect of the distal tibia. An isolated injury to this ligament is often called a high ankle sprain. The bony architecture of the ankle joint is most stable in dorsiflexion. Thus, a sprained ankle is more likely to occur when the ankle is plantar flexed, as ligamentous support is more important in this position. The classic ankle sprain involves the ATF, or the anterior talofibular ligament, which is also the most commonly injured ligament during inversion sprains. Another ligament that can be injured in a severe ankle sprain to the lateral side is the calcaneofibular ligament. The human foot is a highly developed, biomechanically complex structure that serves to bear weight of the body as well as forces many times the weight of the human body during propulsion. About 26 bones in the human foot provide structural support. They can be grouped into three parts as follows. We have 7 tarsal bones, 5 metatarsal bones, and 14 phalanges. Apart from these main bones, the sesamoid bones help to improve function and are often found as variants of the accessory bones. The foot itself can be divided into three parts: the hindfoot, the midfoot, and the forefoot. The hindfoot is composed of 2 of the 7 tarsal bones, the talus and the calcaneus. The midfoot contains the rest of the tarsal bones, including the 3 cuneiforms: medial, intermediate, and lateral, as well as the cuboid and navicular. And the forefoot contains the 5 metatarsal and 14 phalanges. The metatarsals and phalanges look much the same as the metacarpals and phalanges in the hands. The toes are counted 1 through 5, starting at the big toe and working towards the pinky toe. The first toe has 2 phalanges, a proximal and a distal phalange. Toes 2 through 5 have 3 phalanges each, a proximal, middle, and distal phalange. A sesamoid bone is a bone embedded in a tendon. Sesamoids are found in several joints in the body. In the normal foot, the sesamoids are 2 pea-shaped bones located in the ball of the foot beneath the big toe. Acting as a pulley for tendons, the sesamoids help the big toe move normally and provide leverage when the big toe pushes off during walking and running. The sesamoids also serve as a weight-bearing surface for the first metatarsal bone, absorbing the weight placed on the ball of the foot when walking, running, and jumping. The joints of the toes are very similar to the joints of the hands. There are 5 metatarsophalangeal joints. Each metatarsal phalangeal joint allows the movements of flexion, extension, adduction, and abduction. Each joint has a medial and lateral collateral ligament for support. As far as the interphalangeal joints, the first toe is different than toes 2 through 5. The first toe has only 2 phalanges and 1 interphalangeal joint. Toes 2 through 5 have 3 phalanges and a distal interphalangeal joint, as well as a proximal interphalangeal joint. Only the movements of flexion and extension are allowed at the interphalangeal joints of all toes. The interphalangeal joints have a medial and lateral collateral ligament for support as well. The plantar fascia is the thick connective tissue which supports the arch on the bottom or plantar side of the foot. It runs from the tuberosity of the calcaneus forward to the heads of the metatarsal bones. Under normal circumstances, the plantar fascia acts as a shock-absorbing bowstring within the arch of the foot. If tension of this bowstring becomes too great, irritation or inflammation can occur, causing pain. Chronic inflammation may eventually cause a heel spur or plantar fasciitis. The arches of the foot, formed by the tarsal and metatarsal bones, strengthened by ligaments and tendons, allow the foot to support the weight of the body in the erect posture with the least amount of weight. Pes cavus, also known as high arches, is a human foot type in which the sole of the foot is distinctly hollow when bearing weight. That is, there is a fixed plantar flexion of the foot. Population-based studies suggest that the prevalence of the cavus foot is approximately 10%. Flat feet, also called pes planus or fallen arches, is a postural deformity in which the arches of the foot collapse with the entire sole of the foot coming into complete or near complete contact with the ground. Some individuals, an estimated 20 to 30% of the general population, have an arch that simply never develops in one foot or both feet. There is a functional relationship between the structure of the foot and the biomechanics of the lower leg. The arch provides elastic, springy connection between the forefoot and the hindfoot. This association safeguards so that a majority of the forces incurred during weight-bearing of the foot can be dissipated before the force reaches the long bones of the leg. In the foot, we have 3 arches. We have our medial longitudinal arch, which can be seen on the medial side of the foot. So right now you're looking at the medial longitudinal arch, or lack of, in all of these images. We also have a lateral longitudinal arch, which is on the lateral side of the foot. And then we have a transverse arch. Our transverse arch is along the width of the foot at the ball of the foot. The length of your toes should be considered for the purchase of shoes to make sure they fit. All shoes should be measured to the longest toe. In addition, biomechanically speaking, the longest toe typically carries more of the weight-bearing load during the push-off phase of walking or running. If you have different toe abnormalities or deformities, it can lead to different types of injuries. If your first and second toe are the same length, then you have a square foot. Approximately 9% of the population has this type of foot. If your second toe is longer than the first toe, then you have a Morton's foot or a Greek foot. Approximately 22% of the population has this foot type. If your first toe is longest, then you have an Egyptian foot. Approximately 69% of the population has an Egyptian foot. Since the great toe was designed for carrying more weight and load than the second or third metatarsals, it is not uncommon to see stress fractures in individuals who have a Morton's toe.